Good evening, ladies and gentlemen. My name is Heather Marsh, and I am the president of the Barbados Cancer Association USA. It is my distinct pleasure to welcome you to the Dr. Deborah Brathwaite Annual Cancer Symposium. We are delighted to see all of you Before we get started, I would like to call upon Reverend Dr. Laurel Scott, pastor of the Wakefield Grace United Methodist Church, to offer a blessing on this evening's program. Dr. Scott, welcome.
Thank you for inviting me to give the opening prayer. It's my pleasure and honor to do so because Dr. Deborah Brathwaite was a family friend. And our mothers were actually friends, as friends and workmates. And so it's my pleasure to give the opening blessing. So let us be in a spirit of prayer. Holy One, we thank you as we gather today. We thank you for all of the people involved in the work of healing, in the healing arts. We thank you for the gift of intelligence and the gift of understanding which you give to those of us who are involved in healing. Those who constantly search for cures, those who attend to those who are sick, those who search out the ins and outs and the details and the engineering of diseases. Especially today, we ask your grace upon those of us involved in the treatment of cancer. We pray for the work that is being done by BACA and CAMSA in the name and in the honor of Dr. Deborah Brathwaite, your daughter, who was so skilled and so dedicated to her work. And so as we go forward this day, as we hear from those who have been chosen to help us understand and to help us heal, let us continue, O Lord, to give you thanks and praise for each and everything that has been given to us through our understanding of the body and our understanding of the ways in which the body works. So bless us all, every participant. May we learn from this session more than we knew before, and may we be able to apply it so that our lives may be better and that we may share what we know with others. I pray this prayer in your holy name. Amen and amen.
Thank you, Dr. Scott. So this program has been named in the honor of Dr. Deborah Brathwaite. She was the past president of the Caribbean American Medical and Scientific Association, also known as CAMSA. And she was a respected member of the Physical Medicine and Rehabilitation Department at Kingsbrook Jewish Medical Center in Brooklyn, New York, until her passing in 2013 at the height of her career. She was instrumental in bringing our annual Cancer Symposium to Kingsbrook, and we are pleased to honor her today and to continue her legacy. We are also privileged to have members of her family with us this afternoon, her sisters, Gail Brathwaite and Sandra Agard. And I want to extend a warm welcome to both of you. This program is a collaboration with the Barbados Nurses Association of America, which is led by President Dr. Cicely Wilkinson, and also CAMSA, which is led by Dr. Ed Aline. We have been hosting these educational sessions for almost 20 years. And last year, we delivered our first virtual symposium, which was well received. And here we are again, because we cannot allow the pandemic to prevent us from bringing this very valuable information to you. These educational programs are created to provide you with the information needed to help you make informed decisions, along with advice from your primary care physicians. The theme of today's program is cancer diagnosis and treatment, past, present, and future, which is very timely because they have been significant advances in cancer treatment over the past few decades. With targeted therapies, new approaches and technologies, and improvements in conventional treatments like chemotherapy, research is moving forward in ways that are bringing hope to families and ensuring a better quality of life to more patients touched with cancer. So with that said, I'm going to turn things over to the experts to share this information with you. So right now, I'd like to call on Dr. Ed Aline, who is the chairman of the planning committee for this program, and also the president of CAMSA, and he will introduce the moderator. Ed?
Well, let me give a quick welcome to all of you. And it's my distinct pleasure to introduce our moderator this evening, Dr. Diana Callendar, who is a clinical hematologist and oncologist. She's eminently qualified and of course will be able to bring together all of the speakers. What is missing, she will fill in. What is not missing, she will add, and make this a lively, worthy, and intelligent presentation. Again, I welcome Dr. Diana Callendar.
I nearly forgot to unmute myself. Thank you very much, Dr. Aline, for that welcome. It is a privilege to be here with you all and with this very distinguished group of speakers. I would first like to introduce Dr. Harold Harvey. Dr. Harvey attended Harrison College in Barbados and graduated from the Faculty of Medicine at UWI in 1969. He did an internship at the Queen Elizabeth Hospital in Barbados, and then an internal medicine residency at Lemuel, Shattuck, and Faulkner Hospitals in Boston. He then went on to do a fellowship in medical oncology at Tufts University Medical Center Hospitals, also in Boston. Dr. Harvey joined the faculty of the Milton S. Hershey Medical Center at Pennsylvania State University as an assistant professor of medicine and remained at that institution. He became a professor of medicine, and from 1984 to 2016 was the director of the Hematology Oncology Fellowship Program, and so helped train generations of oncologists. He has won the Distinguished Physician Award for Excellence in House Staff Teaching, the Dean's Award for Teaching, and has been recognized for extraordinary patient satisfaction, something we wish for all of our oncologists. He retired in 2020 as Emeritus Professor of Medicine. Dr. Harvey will speak on cancer diagnosis and treatment, past, present, and future from the US perspective. Dr. Harvey, I will give you a 5-minute heads up because I know you have a lot to cover. Dr. Harvey.
Thank you very much, all. I'm very pleased and honored to be joining this presentations and to make friends with some of my colleagues from years back. This first slide shows the Penn State Hershey Cancer Institute, where I did a lot of my work. But I want you to look carefully and see that it says Penn State. I want to remind you that today, our football group playing a very important game, and I hope you will all cheer on for Penn State. So I'm counting on you. I'm very pleased to have been invited to talk to you and remember the great work that Dr. Deborah Brathwaite did in her lifetime. It's a real pleasure to have been invited. What I thought I would do is talk about the current modalities in cancer care, at least some of them, and try to answer the question, how in fact are we doing? As we go through this, I'd like to have you put some emphasis on cancer in minorities. I'll talk a little bit about my views on screening for cancer these days, talk about some of the newer diagnostic tests that are moving us forward, say a word about radiation therapy, even though that's not my field, give examples of chemotherapy and the new drugs that are really moving us towards cure, I trust. I'll talk a little bit about new hormonal therapies, since this was an area of my research for several years. I'll talk a little bit about bone marrow transplantation and suggest that in Barbados, this is a therapy that we might need to get into. I'd also like to mention what is happening in the role of immunotherapy in oncology, a new topic that we call IO, immunology oncology. Say a word about cancer vaccine, and then end up talking about some of the toxicities that we incur when we treat patients and how we do our best to manage them. We're talking about, I mentioned a special risk in minorities, particularly in Blacks, and talk about the disparities of certain of these cancers. I mentioned 5 of them, but there are more. Certainly triple negative breast cancer is a particular problem and disparity in Black women. Cancer of the cervix, where we're doing better in the islands, but that too obviously needs even more attention. Prostate cancer is a problem in Black men in this country, worldwide as well, but particularly in the Caribbean area. Multiple myeloma is another disease that I would consider some disparity, because the incidence in Black folk is considerably higher than in Caucasians. And for lung cancer, there is a clear disparity in men especially, but in women as well. And I think we suffer from some of what happened when cigarettes were particularly given to young Black people, and hence lung cancer that followed. So this is a disparity that we should think about. So I will begin by talking about cancer screening, benefits, and controversies. Lung cancer is the most common cancer in many countries and the most common cause of cancer death. So it would be really nice if we had a way of finding, diagnosing lung cancer easily and quickly. Up until recently, the fact is we've not been able to do that. We tried chest x-rays, they don't work in screening. However, there are now data showing that low-dose CT scanning can in fact pick up early disease and therefore lead to a better outcome. And so currently in the United States, we're using low-dose CT as a screening technique, particularly in patients, prior smokers, heavy smokers, around age 50. And this is beginning to yield, I think, some product. We are beginning to do better in diagnosing this disease very early on. Colorectal cancer is interesting, particularly in Black folk. There is now an increased incidence of colorectal cancer in patients of younger age. We don't know why, but this is something that's being researched. I think you'll all remember, for example, Chadwick Boseman, who died at an early age from this disease. So the disease is getting more serious at an early age. Screening then becomes very important. There are many techniques for screening. We now think that colonoscopy as a first screening test should probably be done at age 45. And this is a younger age than it used to be. There are other tests like hemoccult testing or fecal immunochemical testing, the FIT test. Cologuard is another technique that we're using where patients can send to a laboratory the Cologuard instruments and get an answer back fairly soon. One of the things that we've noticed is that colorectal cancer is occurring more frequently now in the right side of the colon. And there are some reasons for that and some research ongoing suggesting that there are differences between cancer in the right side versus the left side. The point, though, is that screening in this disease at a young age is very important and should be increasing. Prostate cancer is a common disease in African-American men, usually diagnosed and screening by digital rectal examination, which is not a pleasant thing for most men, and a PSA test, a blood test. The United States Preventive Services has issued what I consider some controversy. I don't believe fully in what they've said. I believe that men, Black men, and Hispanic men in this country should be tested more regularly. The United States Preventive Task Force disagrees with that, and I disagree with them. Breast cancer. Turns out that mammography is still the best test for screening for this disease. However, things are changing and I think improving. For example, in the States, in the United States, we now routinely use three-dimensional testing as part of the mammogram evaluation. I suspect that this is not true in places like Barbados, and this could easily be changed. There is some research going on the use of MRI, not fully, as for screening, not fully accomplished yet, but I think the research is very interesting. One of the things that we see particularly in Black women is breast density. And one of the things that we're doing at our institution is marrying or combining mammography with ultrasound to try and detect breast cancer in the dense breast. You might be interested to hear that artificial intelligence is now being used to improve the skills of the mammographer. And I think this has good promise. Again, I personally disagree a little bit with the United States Preventive Service, which is suggesting that mammography screening starts later, that it be done not necessarily annually. And I personally think that this is wrong, but more about this you'll hear in the new publications. Radiation oncology has made a considerable advance. I know for a fact that in the islands, in Barbados in particular, we are still limited the use of the older machines, I would say, the cobalt machines, for example. I think that's fading in this country, and that we need to think about more precise and better instruments. Linear accelerators for external beam therapy is really what we do in the United States, and I would like to see these changes happen in the Caribbean. There are several forms of brachytherapy. We certainly use brachytherapy for cervix cancer on the islands, but there are other forms of internal radiation. That's what brachytherapy is. stereotactic body radiation therapy, where we can radiate larger volumes of disease on parts of the body, is also very useful in the US, and I think should be considered in the United States. There are other approaches, for example, cyber knife or gamma knife or trilogies. These are techniques to treat certain areas of the body, particularly in the brain. So brain cancers can be more precisely treated now with these techniques. Perhaps the oldest, not the oldest, I meant the newest technique that's coming on board is proton beam therapy. However, this is limited to, I think, less than 10 instruments in the country. The idea is that you can get better and greater precision in treating a target, such as a tumor, and sparing normal tissue. It allows for decreasing motion, like breathing and so on, in the treatment, and it uses very high energy therapy. The skin damage and other toxicities are decreased when compared to other forms of radiation therapy. This is an expensive undertaking, and I would expect that this won't happen very soon in Barbados, for example. On the other hand, some of the other techniques I think should be practiced, and linear accelerators should replace cobalt machines, in my opinion. Talking a little bit about new diagnostic tests, and these are just a few examples. Increasingly in the States, we're using the PET scanning, positive emission tomography. Use this to stage solid tumors and lymphomas. And it'd be hard to treat patients, for example, with complex lymphomas without the use of this test. And I think we would want to see this show up in the islands. BRCA testing for gene mutations in breast cancer and ovarian cancer, I think are a very important part of therapy. There's studies showing that in parts of the United States and in Africa, this is being underused. And this is a test that can be done quite simply, I believe. You can test either saliva or blood. And this is one of the changes I'd like to see fairly soon. For the breast cancer doctors and breast cancer patients, let me mention another test, the Oncotype diagnosis. It's a combination of gene testing in patients with primary breast cancer who have estrogen receptor positive disease and who are undergoing primary therapy. And I'll show you how this test has helped in reducing recurrence in breast cancer, and in particular, reducing the need for chemotherapy in some of these patients. The newest and most appealing approach is genomic testing of tumors. Increasingly in our institution and others in the United States, for complex patients, we will get testing of the genes in their tumor that are causing the progression of the disease. And this is becoming, I think, a widely used approach. I would like to see this appear in the Caribbean, even if you couldn't do the test. Tumor sites, tumor specimens could easily be transferred and tested and returned to patients and doctors in the Caribbean. This is an example of what I was talking about in breast cancer, where we have gene arrays. This is a particular gene array using 16 genes, and we can divide these patients, who, by the way, are ER positive patients, meaning that they have overall a fairly good prognosis. And when these gene arrays when patients get these tests done, we can decide or determine which patients have the best outcome. So, for example, in the green arrow, in the green curve, I showed 10 years survivals for the patients who have a score. I forgot to say that there's a scoring system, and women who have a good score, a low score, do very well. And the important thing now is that we're learning that these patients don't need chemotherapy. We used to give every patient with breast cancer almost chemotherapy, and we're now cutting down on that habit, that practice. However, the scores can also tell us about the patients who do require systemic chemotherapy. The group in red, for example, their 10-year recurrence is higher and the survival is lower, and we treat those patients more aggressively than patients in green who require no chemotherapy and simply hormonal therapy based on the scores you see on the left. One of the things that I had a good experience with is the development of a new therapy for a particular type of breast cancer. What you see on your left is a breast cancer cell that has a HER2 gene. HER2 stands for human abdominal receptor. This particular protein is a factor that we can detect in the cell. We can detect in the numbers of within the cell itself, the numbers of genes. So this is a very regular, fairly good behaving breast cancer. On the other hand, to the right, there are cancers that we discovered several years ago now that involve about 20% of patients. Now, you see here that this cell has large numbers of these growth factors, these protein receptors, and large numbers of genes. So this kind of breast cancer is described as being overexpressing for the HER2 receptor or amplification for more of the genes that make this protein. This used to be a type of breast cancer that was very malignant, hard to treat, and patients died at young ages and early from this breast cancer. However, research has shown that we now have therapies that in fact treat this previously very aggressive cancer quite well. I said about 20% of these patients have breast cancer of this type. Now we have ways of targeting the HER2 protein and sparing the life of many of these patients as compared to what happened 10, 15 years ago. Now, an example of this is Herceptin of trastuzumab, but there are other antibodies. There's pertuzumab antibodies, and these are combined with chemotherapy, and now we're seeing much greater improvement compared to these kinds of patients as compared to what we had to contend with a few years ago. These particular antibodies are interesting because now they are being chemically linked to other substances, very potent toxic agents, which are carried into the cancer cell and deliver a lethal payload in the cell. It's like a Trojan horse kind of approach. In addition to the antibodies, we also have oral agents which target the HER2 or some of the other factors, HER3 and HER4, very effectively. So the use of these agents in breast cancer is a considerable step forwards in my view. And I believe that women living in the Caribbean should have access to these life-saving kinds of therapies. One of my areas of interest and research has been in hormonal therapies of breast cancer. And recently, there are new examples of hormonal therapies. They're called CDK4 inhibitors in women who have estrogen receptor positive breast cancer. This is taken from a slide done at ASCO a few months ago, in which patients were treated with a standard form of endocrine therapy. In this case, it happens to be a drug called fulvestrant, or combined with one of these newer agents, the CDK4/6 inhibitors. And what you see in blue is a significantly greater survival of the patients who are treated with the double approach, the new drugs as well as standard hormonal therapy. Excuse me. Now, in metastatic breast cancer,
Dr. Harvey, you
yes,
have just under 5 minutes.
I show you the three drugs that are being used. I show you the different studies that have been used. And what I want to show you is that in Black patients, they are poorly represented in these studies, sometimes not even mentioned. And it's not clearly true that we don't know if these agents work as well in Blacks as not. So time is running out. Let me tell you that we use a lot of bone marrow and stem cell transplants, either allogeneic or autologous therapies for leukemias and lymphomas and multiple myeloma. And I would like to see this get into the Caribbean because these are extremely useful therapies. There are examples of cancer vaccines in prostate cancer. HPV vaccine is clearly reducing the incidence of cervix cancer, and we ought to be using this more than we are. BCG is now being used to treat superficial bladder cancer, and that's an easy thing to do, and I'd like to think that's happening in the islands. A new approach is what's called immuno-oncology and precision medicine. This came as a result of understanding the biology of the human genome. Now we're studying the cancer genome, and there are drugs that have derived from this work, and some of the immunologic pathways that we can use to target very specifically. The idea is that not one cancer is the same as another. And so we're learning to be precise in the application in these patients of immunotherapy in oncology. Let me say very quickly that toxicities occur with these patients, and we're doing better in managing the toxicities. Nausea and vomiting, we have very important antiemetic drugs because we now understand how it is that chemotherapy causes nausea and vomiting. There are patients with low blood counts, but we have growth factors, which decreases the risk of infections. Fatigue is a very common problem in cancer and cancer therapy. At our own institution, we have done a lot of work looking at exercise. And surprisingly, exercise is a considerable relief to patients when properly given. Now, a lot of the medicines and so on I mentioned are toxic. One of the toxicities we have to bear in mind is financial toxicity. This is a way that slows us down, and we need to be aware of that. Overall, though, I argue that we are making progress. We have a better understanding of the cancer biology. We have a better understanding of how cancer cells work and how they can be destroyed. We have, I would say, an increasing number of tools in our toolbox. Patients are living longer. In fact, there are some patients and some diseases where we're beginning to think that maybe we can change this disease into almost a chronic disease. We may not be able to treat it in a curative fashion, but just like in diabetes or hypertension, we can manage these diseases for a long time. I believe that there are cures in some of these cancers that are at a close horizon, especially, for example, in the pediatric tumors. As I mentioned, success is somewhat stymied by under-resourcing and lack of funding. And that's a problem that I think those of us who have left the Caribbean should be helping with back home. At the last ASCO meeting, this phrase came up, which I rather like. There has to be equity for every patient. Equity every time we see a patient or a family. equity in every place, be it in the Caribbean, be it in the United States or Europe. And I want to see that approach expanded as we go on. Thanks for allowing me to race through this. Thank you very much.
Thank you, Dr. Harvey. We actually have a couple of extra minutes. I think that Dr. Nichols has been detained. And I'm just wondering if you could maybe talk a little bit, and we can come back to this later in the Q&A, but maybe you want to expand a little bit more on the toxicities and the financial toxicity before we go on to our next speaker, who will be Dr. Mays.
Well, yes, toxicities, I mean, you well know that what really made a lot of our patients not want to get therapy or fear therapy was how sick they got from the therapies. But now we're doing a lot better. We understand the mechanisms of these toxicities, and we have treatments designed for that. So I think both radiation therapy and chemotherapy are not as toxic as they used to be. And I think it's important that when we treat these patients, not only to get rid of the tumor, but there is the heartache, the problems with the patients and their families that we have to address as well. So it's a very broad area that I think can be applied quite well and quite cheaply to improve a lot of these patients.
Thank you. I think what we will do next is go on to Dr. Mays. If you're ready, I'll just introduce Dr. Simone Mays, and then we will see if Dr. Nichols is able to join us a little later or not. So Dr. Mays, Dr. Simone Mays is a board-certified general surgeon specializing in the treatment of benign and malignant breast disease. Dr. Mays earned her medical degree at the Drexel University College of Medicine, and she completed her general surgery residency at Brookdale Hospital and Medical Center. She subsequently completed a breast surgical oncology fellowship at the Mainline Health Bryn Mawr Hospital. During her residency training, Dr. Mays dedicated a year to research at the Weill Cornell Medical College Breast Center, leading to several publications aimed towards improving the treatment of breast cancer in elderly patients, improving outcomes in patients with complex comorbidities, and the benefits and better outcomes associated with nipple-sparing mastectomy. Dr. Mays has a special interest in improving breast cancer outcomes within underserved, marginalized communities. Dr. Mays will speak to us on pain management. Dr. Mays?
Yes, thank you again for inviting me to this very important forum. As mentioned, I'm a breast surgical oncologist at Brookdale University Hospital, and I will be talking with you primarily regarding postoperative pain management. I don't particularly take care of patients' chronic pain related to different malignancies, so I don't want to kind of overstep my expertise in that fashion. So if I may just share my screen. Okay. So one of the newer programs that have been implemented, not only with respect to postoperative pain management in breast cancer patients, but it actually came into practice primarily with the management of pain related to colorectal surgery. And it has now been utilized in other post-surgical management of other cancers, such as breast cancer. So the program is called an Enhanced Recovery After Surgery, short for ERAS protocol, which improves the overall patient experience with respect to immediate postoperative pain, as well as in the several days, weeks after surgery. So part of that program involves one, perioperative management, meaning when the patient comes for surgery prior to any type of incision being made, creating a protocol that improves the patient's overall pain experience immediately postoperative. And that involves one, oral acetaminophen and gabapentin, which have been shown, if given just prior to surgery, improves the patient's pain and, again, the immediate postoperative period, and also, more importantly, reduces the utilization of opioids. As we all know, the opioid epidemic is something that has really impacted many communities, and more specifically, the African American and Black communities. So finding ways in order to manage patients' pain appropriately without the use of opioids has become a key point that a lot of clinicians have been trying to find other programs or ways in which to do this. So again, in the perioperative period, the use of oral acetaminophen and gabapentin given perioperatively reduces the use of opioids in the post-op period. Specifically with breast cancer, mastectomy, a commonly used operation to manage women's breast cancer, a pectoral nerve block has shown to significantly improve, again, the patient's postoperative pain, as well as reducing the need for opioids after a mastectomy. And this is actually one thing that was used rather frequently, or more frequently, I should say, in the COVID epidemic, because as you know, at the height of the pandemic, a lot of elective surgeries were being postponed or canceled unless it was a same-day procedure. So the utilization of pectoral block really took hold because it allowed patients to undergo mastectomy and go home the same day. Typically, mastectomy patients would have to at least stay overnight for that initial perioperative pain management. But the pectoral nerve block has, again, significantly improved the patient's postoperative pain and allowed for discharge on the same day with respect to mastectomy. An additional tool that's part of the ERAS protocol is the injection of a long-acting anesthetic intraoperatively. So after you've completed your operation, prior to closure, injecting a long-acting anesthetic, again, improves the patient's immediate postoperative pain, as well as reduces the need for opioids in the first 24 hours after surgery. And the last thing with respect to the ERAS protocol, specifically related to breast cancer operations, is the use of IV NSAIDs at the conclusion of the surgery. So it's really important to work very closely with your anesthesiologist and coming up with a plan for the postoperative and perioperative pain management of patients. And one additional tool, sorry, let me see. Is the need for when we are discharging our patients home, how are we going to manage their pain once they have left the hospital? So again, there has been a significant movement away from the blanket prescribing of opioids in the postoperative period for breast cancer patients and other patients who undergo cancer operations. So one of the modalities that has been shown to be as effective as opioids is the use of NSAIDs in combination with acetaminophen. It has been shown again to decrease the need for opioid usage. And one of the things that is really key with the NSAIDs is that there have been studies that have looked at postoperative bleeding. That's a big concern when we're talking about operations. And we do know that NSAIDs have been linked to bleeding complications as it relates to other chronic use. But there have been a number of studies that have specifically looked at the use in the immediate postoperative period, and that has been shown not to be the case. So it is safe from a bleeding complication standpoint to prescribe your patients in the immediate postoperative period NSAIDs rather than sending them home on a narcotic such as an opioid. And two of the most commonly used NSAIDs is diclofenac and ibuprofen in combination with the acetaminophen, and taking them alternating. So you send the patient home with instructions to take the NSAID and acetaminophen alternating every 4 to 6 hours as needed. And again, studies have looked at patients' reported pain postoperatively, and they have been shown to be as effective as opioid use without the negative impacts of potential addiction and dependency in the future. And one of the other things that is really important to keep in mind when we're talking about pain management is exercise. It's one of the things that we often overlook as clinicians and counseling our patients. So when I have a patient who has a new cancer diagnosis, I have a conversation with them about physical activity and preparation for their surgery, and encourage them to begin a walking regimen so that in the postoperative period, they have a plan in place. And this has definitely been shown to improve patients' overall outcomes as it relates to cancer in general, but more specifically with respect to this topic with the management of pain in the immediate postoperative period. And also it's very important with resistance training and stretching. You know, before it used to be this recommendation, particularly when women have lymph node biopsy or axillary dissection, that they have to restrain from, you know, moving the arm or lifting heavy objects. And that's just not the case. It is very important for patients to remain mobile and do stretching and also resistance exercises with the upper extremities, even after they have undergone a lymph node biopsy or axillary dissection. So my presentation is a bit short because I just wanted to focus in on the pain management in the perioperative period. I would be happy to answer any questions at the conclusion, not only with respect to pain management, but management and diagnosis of breast cancer in general. Thank you again for having me.
Thank you, Dr. Mays. I actually already have a question for you.
Yes.
So please, as you see in the chat already, please remember to put any questions that you may have in the chat, and we will get to them after the next section. So next we have, as you know, cancer management is extremely complex, and it is very distressing for many patients with lots of different outcomes that need to be managed. And so we are very fortunate to have a section on cancer survivors. And this will be facilitated by Dr. O'Neill Paris. Dr. Paris is a graduate of Yale University with a BS and an MD from Columbia University College of Physicians and Surgeons. He also has an MPH from Columbia University School of Public Health. Dr. Paris is board certified in pediatrics and a fellow of the American Academy of Pediatrics, and currently practices pediatric, adolescent, and young adult medicine in Lake Success, New York. He is on the attending staff at Cohen Children's Medical Center and North Shore University Hospital. Dr. Paris is chairman of the Barbados Diaspora Collaborative USA, a 501c3 organization whose mission it is to support diaspora initiatives targeting Barbados in the field of health, culture, and the arts. He is also chairman of the Barbados Association of Cancer for Cancer Advocacy, a Barbados charity that is working in conjunction with the Living Water Community, another Barbados charity to help establish a freestanding hospice in Barbados. Dr. Price will introduce two very special guests, Ms. Aline and Ms. Ford Powell, and will facilitate a discussion on their experiences. Dr. Price?
Thanks very much. And I just want to mention that Dr. Nichols will not be joining us today. So we get a Miss Barbados perspective, which is something that we've kind of valued in our past symposia, because it updates us on what's happening there. And there's some cross-fertilization with respect to what's happening here. And we get to see how we can help from this end. But Dr. Harvey did make allusion to some of the things that he thinks should be happening and that are happening in the Caribbean at the moment. And we do have on the webinar, I see Barbadian Deanna Silvers, who is president of the Barbados Association for Palliative Care, and she may be able to fill in some of the gaps in terms of the availability of things like PET scans and that sort of thing. So we'll see. Yeah, okay. Two special guests indeed, and two cancer survivors. I'm going to have them give their very brief presentation, and they're going to try to tell us how they think technology advances in cancer diagnosis and treatment made their lives better. I have Sandra Aline, and then we're going to have Betty Ford Rodal. So Sandra Aline, why don't you go ahead and take the floor?
So sorry. Good evening. My name is Sandra Aline, and I'm a 64-year-old cosmetologist. I was diagnosed with stage 3A breast cancer around September 23rd, 2011. That is after losing my mom's oldest sister in 1981 from breast cancer. And then in 1983, I lost my mom at a very tender age of 46 from breast cancer as well. So, you know, that made me, it was scary for me at first, and I have two brothers, and it was also scary for them, being their older sister. But I was able to be with a medical team at Brooklyn Hospital here in New York, because my mom's older sister died in New York, and she battled it for like a year and a half. And then my mom was in Barbados in 1983, and that she lasted just 6 months. So yes, for myself and my family, it was a scary time. But I'm so grateful and thankful for the research that's going on now, because I'm still here. Look at me, I'm still standing. And I was told at that time that it was an aggressive form of cancer that I have, breast cancer. So I went through the stages of treatment. I had 24 weeks of chemotherapy. Then I had 7 weeks of, before the radiation, because I had 24 weeks of chemo. And then I opted for a double mastectomy in 2012. That was May of 2012, right after the chemotherapy, because it was to shrink the tumor. And then after that, I had 7 weeks of radiation, Monday through Friday. So I'm a product of a medical team from Brooklyn Hospital here in New York that assisted me, and I'm so grateful and thankful to God and them that I'm still here. So I, after the, you know, going through the different stages of treatments and stuff, then I was on a 5-year break with the pill Arimidex for 5 years. That I finished that 2017. I think it was in November 2017. And then in 2018, I started experiencing some pain in my lower back, and my running down my leg. It's, you know, some of us thought that it was like sciatica, but after consultation with the doctors at the hospital and my oncologist, and they put me through a series of tests, I was told then that the cancer had metastasized to my bones. So now I am in treatment for that. I'm on Ibrance, and I know guess I'm going to be on this for the rest of my life. I get shots every 2 shots every month. Every 3 months, I get another shot with those 2 shots. And unfortunately, in the times with my aunt and my mom, it wasn't this advanced treatment and research. So I am so grateful to the research teams that are working for us, cancer patients, and helping us through this difficult journey. I really I'm doing okay. I do get pain at times, but it's nothing I scream about. I remember the first doctor said something about fatigue. Yes, that is something that is with me. But knowing some of my friends that are on knowing me know that I'm an energizer bunny, so I like to get up and move around. So I am so grateful. My only thing with, I wish that helping us cancer survivors is that we would try to target or focus on advocacy program for persons that don't have assistance, don't have, because I can tell you, and I can attest to this, I have a beautiful family circuit. I have friends that are so kind and helpful to me, knowing that I'm a hairstylist and not practicing hairstylist anymore because it's difficult with the right arm and I'm a right-handy. So that is kind of hinder my profession, but I still stay on the fabulous line. I give tips, to my friends that I have that in Florida, hairstylists. I do, they still call and ask me for certain advice on hair coloring. So I still active in the industry of being a hairstylist. So that's my contribution in saying that it's an ongoing thing for me, but I am still here. I am grateful to the Almighty for keeping me, and do pray and hope that we will soon have a cure for the breast cancer that, I don't want to tear up, but the breast cancer that it seems as though it ran on my side of the family. And unfortunately, I was had to go through the trauma with my aunt and my mom, which is really hard because my mom was only 46 and now I'm 64. So I'm giving, with thanks and prayers. So if there are any other questions that anyone want to ask me a question after, I'll still be here. But that's basically my little story in a nutshell.
Thank you, Sandra, for sharing that story. And I think this is very instructive. We have 1981 and 1983, your mom, and 10 years and 7, and then intervening years to 2011 when you were diagnosed. And my question for you is, what happened in those intervening years in terms of your medical care and screenings, et cetera? If you can address that, that would be great. And then I think the oncologists on the panel can talk about advances that would have happened in between from 1981 to 2011. We don't know what was happening in Barbados. At least I don't know what was happening there back in 1981 when your aunt died. Your mother died here in 83.
No, my aunt was here in New York in 81. My mom was in Barbados in 1983.
Yeah, that's right.
Yes.
Okay, sorry.
Yes.
Right. So I'm sure there were differences in the treatment approach. And
yes.
What were you told when with this family history, and did you have specifics about your cancer markers, et cetera?
With my mom, hers was like in the space of 6 months, she was gone. But with me, after my mom passed, every year I had my mammograms. But for some reason, in 2010, because I lived in South Florida, and in 2010, being a hairstylist, I was doing lots of hair shows and stuff. And remember, from 1983 right through to 2010, I was doing yearly mammograms. I after my mom died, I developed more, and they said I had fibrocystic breasts. You know, I had voluptuous girls. I call them girls, and I I got the test done yearly. But 2010, for some reason, I missed 2010. And I'll say this, it was part of my fault, because being a hairstylist, I worked for a hair company. So I was doing a lot of hair shows. And you're doing hair shows and you're on stage and you're blow drying and stuff.
Sandra, one second, let me interrupt you.
Sorry.
Were any genetic studies done with the family history that the doctors knew about? They knew about your mom and your aunt. Did they do any genetic studies at all?
No, only after when my aunt died first. Then my mom was, she had the issue, and then she went and it was after the lump came up under her arm. That's when, she went and got her testing.
All right, I think oncologists are going to discuss this a little bit more and what should have been done, etc. So in the interest of time, I'm going to move on now and ask, and
that's
ask
okay.
Second speaker, Betty Ford Bouvel, to give her story.
Good evening, everyone. My name is Betty Ford Bouvel. Before I get started, I would just like to say that I'm not the only one that was afflicted with this breast cancer. My dad succumbed to breast cancer. One of my sisters already passed with breast cancer. Another sister with ovarian cancer, and my brother in Barbados just had prostate surgery. Another nephew had prostate surgery, and my niece here with breast cancer also. So in saying that, in 2016, I was a 60-year-old who was diagnosed with breast cancer. TIENI, ER positive, HER2 negative, invasive ductal carcinoma. My treatment started with 3 lumpectomy surgeries and a prophylactic because of the BRCA2 positive mutation. I then started a chemo regime of 4 cocktails along with Neulasta injections. I experienced many side effects, but because of ongoing clinical research and new technology today, my team of specialists at Sloan Memorial Cancer Center were able to try a different treatment. Now I am on Lexapro along with estrogen reception therapy, and this is helping me to reduce the risk of reoccurrence. My body is tolerating this treatment with less side effects. My radiation therapy was a challenging one because my radiologist, with stimulation, had to map out a way to administer the treatment to divert the radiology away from my heart, because the left breast was the one to receive more intense radiation and a boost to that direct site where the cancer was removed. Taking careful consideration not to damage the nearby tissue. So I can say today with confidence that with continued science, a combination of new drugs and clinical trials, we are given a chance to a better quality of life living with breast cancer. I am living proof, for I am alive today.
Thank you very much indeed. I'd like to question a comment that Dr. Harvey made about equity, and it's location, location, location. If you're in one place, there's a good chance that if they have the technology, you'll do very well. If you're in a developing country without technology and diagnostic capability, you may not do that well. And that's why we need to be equitable or promote equity not only for cancer, but for everything else, whether it be HIV, AIDS, or COVID vaccine. We need to be promoting equity globally, in my view. And I think there's some need in presentations that the oncologists can actually expand on. So I'll leave it for the oncologists to kind of take up, where they think they should be going with this. Thank you very much.
Before we go on and ask Dr. Harvey and Dr. May to make a comment on what we just heard, I just want to say both to Ms. Aline and Ms. Ford, both that you both look fabulous. So you're both, are rocking it. So it's wonderful to see you and to hear your sharing with us. Dr. Harvey or Dr. Mays, what are your comments on what you just heard? What are your thoughts?
Well, several. I want to agree with Dr. Paris on two things. I was getting worried that Sandra had not gotten BRCA testing, but apparently she did. And I want to say that this needs to be done more frequently in women who develop breast cancer, particularly with a family history that she had. Also, I would laud her in talking about advocacy, and that helps our family members, patients, as an important guide to success in beating this problem. I also want to congratulate the last two speakers, the patients, about what I was trying to say about making some cancers, breast cancer in particular, a chronic disease. You might succumb to the disease in the end, but I think with new therapies and new approaches, we can keep you living longer in good quality. And the two speakers, it was heartrending to see how you're doing and how you viewed the journey that you've been taking. As far as the question of equity, I think this is important. I think that the whole country can work on it. I think that what's being done in Barbados is helpful, but I think there needs to be more effort. We need to be able to deliver the therapies that are available at reasonable cost. I hear some comments that some things are not being done that, in my opinion, could easily be done. There are other things, of course, which are going to cost a lot. And we, as clinicians and people who are concerned about these diseases, we can get together and find ways of perhaps helping our colleagues in the islands. But we need to get use of the available therapies that are making the rest of the world doing better. So I'm very strongly in favor of working on this whole issue of equity.
Thank you. Dr. Mays, what are your thoughts?
Yeah, I had a couple of thoughts. One, again, I do concur. Both women are absolutely beautiful, and it's so, my heart is so glad to see you guys doing well and managing your disease and getting the care that you deserve. One of the things I wanted to point out with respect to family history is when you have a family history, specifically a first-degree relative, such as a mother, a sister, if they've been diagnosed with breast cancer before the age of 50, in one instance, I believe she said it was 45, her mother was diagnosed with breast cancer. Your screening with mammography, and also currently we're adding breast MRI, particularly in those high-risk patients, should begin 10 years prior to when your first-degree relative was diagnosed. So that certainly wasn't the protocol back in 2010, 2011, but as far as current standards, if you have a family member, again, sister, mother who was diagnosed with breast cancer, particularly if they were under the age of 50, you should start your screening with imaging 10 years prior to when they were diagnosed. And that's certainly when you're talking about women who are in their 30s, they tend to have denser breast. So breast MRI is certainly very key to screening them appropriately. One of the other things that I wanted to kind of mention with respect to mammography is that, as was said in the beginning, I disagree with the US Task Force recommendation for starting screening at the age of 50. Most cancer societies, including the American Society of Breast Surgeons, recommend mammographic screening begin at the age of 40 and should be annually, not every 2 years. And also, as mentioned, if you have denser breast tissue, inquire about the addition of breast ultrasound to your annual screening. And one of the things I did want to bring up is risk. There is a risk stratification. We typically use the Gale model, but what I particularly use is the IBIS, which is the Tyrer-Cuzick risk model, because it takes into account more factors than the other. And so if your risk is calculated above 20%, you should certainly be considering breast MRI as part of your screening. So those women who are considered high risk means that your lifetime risk of breast cancer is 20% or more. And those patients, I alternate every 6 months. They will have a mammogram. 6 months later, they'll have a breast MRI. And with each of those, they see me in my office for a clinical breast exam. So it's really important to understand that screening, particularly in high-risk women, has certainly moved to a new place, as was before even 5-6 years ago.
I would also like to mention along those lines, and along the lines of what Dr. Harvey was saying, is that now there is a lot of research ongoing in terms of personalized risk and using genomics and so on in order to identify those who are high risk and don't only have that such a strong family history, but maybe at high risk for other reasons. Before we go on, I really would like our two special guests to share a little bit about what kind of support did you have? Because we're talking about, despite the fact we're talking about cancer becoming a chronic disease, it still comes with a very heavy emotional burden, as well as financial, psychological burdens. And Ms. Aline, you mentioned that you had a lot of family support, but was there any support from your healthcare providers, the system? Was there any support for you? Ms. Ford-Bovel, what kinds of support did you all get through your journey?
Sandra, I got support from cancercare.org in my first stages, also the American Cancer Society, and in support in the sense of having transportation take me for my radiation treatments. I was also gifted with prosthesis because, like I said, I opted for double mastectomy, and that was my decision. So I didn't want to have reconstruction. So I was given in the early stages, but after 5 years, all that had stopped. I don't get that assistance anymore. But family-wise and supportive group of friends and clients, because of my profession, I have extreme. So, and I say that it's because there's some persons that are not as fortunate as I am, and anything I could do to assist, any kind of assistance, any of the doctors on there could, if you want to use me to talk to or share my, my ups and downs with your patients, that is my give back. Because I think when we're diagnosed with breast cancer, some people see it as a death wish. Shh, don't say nothing, Sandra. But that was never me. I am an open book, and I share it because there were people that helped me. And like I said, a beautiful team at Brooklyn Hospital really guided me some of the doctors there were really kind and guided me in the right direction. And when I first diagnosed, I was given a navigator, but I don't think they have those anymore. It was a breast cancer navigator. And she would call every day, you know, after I had the treatments and stuff with chemo. So that was very helpful. And having caregivers, medical people guiding you. I didn't read a lot because sometimes they would say you need to read on this, and it was scary to read it and you know, have to live. So I rather, you know, I went with the scientists, you know, the ones that are, you guys that are trained and qualified to help me on my journey. So I really listened to the medical team. I had more than one opinion, but I listened to the medical team, and that's key for me. Other people will see it different, but that helped me a lot. And the care that the assistance that I got from those two groups, cancercare.org at the time and the American Cancer Society.
Ms. Ford,
Hello? Yes.
what kind of support did you get?
Well, first of all, I can say that my team of doctors at Sloan Memorial, I'm up to date with my mammogram. I'm due now next month to have my blood work done, and then I would meet with my oncologist, and then I would have my MRI with contrast. So I always keep up with those. And because of the extensive chemo and radiation treatment, I developed lymphedema, which is the fluid in the breast. So I have a lymphedema doctor that I work with to do different treatments to help me with that. And I really had a support team. At the Cancer Society, they helped me a lot. Lots of family members, my church family, my neighbors, and my oncologist, and that whole team. They always call to see how I'm doing and to make sure that I keep my appointments and I'm up to date with everything. So I can say that, you know, I never had a problem in feeling, you know, alone or lonely without any moral support.
That is wonderful. I wish more patients had the kind of support that you all have described. Ms. Sobers, I'm wondering, Dr. Parrish mentioned your role in Barbados in terms of palliative care. Could you say a few words in terms of that kind of support and so on, the experience you think patients need?
Good afternoon, everyone. Good night, I would say. Thank you so much for inviting me to your program this evening. Most of the cases that we receive are those to whom the doctor says, well, there's nothing more that we can do, and we are referring you to palliative care. We have been requesting physicians not to tell the patient, there is nothing more I can do for you, because a part of palliative care is part of that treatment. So you're coming home for quality care. You're coming home for pain management. You're coming home to spend time with your family. You're coming home to do what you want to do the rest of your life. And the question I wanted to ask your two guests, did a physician ever mention to them, there is nothing more we can do for you? That's very devastating. And I want to give you an example. We had a lady who the doctor told her she only had 3 months. And I know her person. That lady went home and counted every day and was dead within 2 weeks. The stress of knowing that I can only have 3 months. So we have been encouraging the physicians not to do that. But I want to mention a little bit, if you would just give me 10 seconds. Over the last month, we have lost 10 patients in death. And the key that we have been noticing within the association is the age level, that the age are no longer in the 80s and the 90s. We're dropping down to as old as 27, a young man with colon cancer. And his mother said his father had it, his grandfather had it. And I'm wondering if sometimes if it is always genes or if we're not looking after ourselves, could he have done something when he first realized that he was not, he said he was started passing blood from the rectum and he just thought it was something normal. So I'm wondering about the
Silvers?
Just frozen.
I think she, yes, maybe the call has dropped. Dr. Harvey, would you like to make a comment on what she just said about that young man and his lack of recognition of what was happening?
Absolutely. As I said in my talk, the age of which we're diagnosing colorectal cancer is clearly decreasing. And we need education. I mean, the problem in this patient, I would suggest, is lack of understanding the processes of cancer and not acting on blood in the, in the stool quickly. So we can do a lot better in public education to diagnose some of these issues earlier. While I have the floor, I would say that I strongly agree with Dr. Mays about issues in breast cancer screening being different from what some publications suggest. I also would like to agree with our patients that the use of advocacy helps patients and families alike. And thank Sandra and her other colleague for doing that in many patients. I also liked when Dr. Mays talked about exercise pre-mastectomy. This is an issue that we've been looking at our institution. And in fact, this is not restricted to breast cancer. It turns out that studies are showing that exercise has a lot of positive effects on different aspects of biology of cancer. And I'd like to hear that this is being more widely used than it has been in the near future, that it should be in the near future. It's cheap.
And along those lines, it also showed to have a lower incidence of breast cancer in women who exercise regularly. So from the cardiovascular to the mental health to the cancer prevention, there's a lot for a brisk walk every day, even if you don't want to be using weights and so on, just to get out there and get moving.
Yeah, the data are getting very strong, both for prevention as well as for cure once a diagnosis has been made. So it's relatively cheap, easy to do, and that's something that we ought to work on.
Dr. Paris, your hand is up.
Right, I want to make a comment about advocacy, because BACA is a quintessential advocacy organization in the diaspora for Barbados, and around since 2003, BACA has donated equipment to Barbados, to the QEH, and supported some of the cancer advocacy organizations in Barbados with donations, and actually we've done other things as well, like supporting cancer survivors with financial assistance. We've actually been instrumental in actually bringing one young person from Barbados for treatment at St. Jude's through the efforts of BACA members. So we're doing that, and BACA also was instrumental in creating the Barbados Association for Cancer Advocacy in Barbados. And that's the entity that's actually looking to help educate the public and also to help create a freestanding hospice that will support Diana Silver's home hospice care, which she does very well. I'm a member of the organization as well, by the way, BAPC. And so we're out there advocating, and we will continue to do so and do our bit from this end and locally in Barbados.
Thank you, Dr. Paris. Dr. Aline, I see your hand up, but if you could give me a moment, because there are some questions in the chat that have been for quite a while. and I like to address a couple of those before coming back to you.
That'll be
Please
fine.
forgive me if I don't, okay?
I think it will be answered in the chat.
Okay, all right. So one of the questions, the first question is from Eleanor Larrier, asking, is there a group that is exploring bringing state-of-the-art cancer diagnostics and treatment to the Caribbean? Centralization of some of the more expensive diagnostics? Where should this be most appropriately be located? And can address issues like cost of acquiring equipment, specialist space implementation, access cost service, travel and accommodation, and cost to centralized location. So can we have maybe a specialist center that will do the diagnostics, and maybe individuals can travel to that center, we can fund that in some way? And what are the potential sources of funding for such an enterprise? So I don't know if any of the physicians or Dr. Aline or any of the advocacy groups have an answer. Dr. Paris, if you can expand on that, what you said just about the advocacy groups, is there a bigger picture?
It comes down to money, basically, and to motivation of an NGO and the government to actually put these services in place. The government currently provides, as you know, health services for anybody who needs it. The rich can always come to the United States, New York and Miami, and get cancer care. But the government is limited in its resources in terms of establishing that sort of focused diagnostic facility. They've had some success in the sense that Rihanna did upgrade the oncology division at the hospital, but there's still lots of room for other things to go on. And I was asking Deanne in the chat about not in the chat, by text, about some of the modalities that were mentioned here, whether or not they were available there. And that's one of the things that we were hoping to get from Dr. Nichols. You know, what do you not have that we have, and how can we help you to acquire what we have that you don't have, basically? As BACA is right, its best to help, but we don't raise the sort of money that you need for some of this expensive equipment and to support the diagnostic testing that would be needed.
I think the question may be getting at a regional cancer center of some sort.
Right.
Dr. Ali, your hand.
To echo what Dr. Paris was saying, I've heard it loud and clear tonight that we need to focus on, I'll say, the developing countries, but in particular Barbados, since BACA is a Barbadian advocacy program. And I wonder if, starting from here, if we couldn't get a coalition together. It's a matter of finding the money, and sometimes our efforts of looking forward to organizations that will support various cancer programs and start from there. And that's one side of it, because I mean, none of us are rich enough to say that we can put up $10 million to buy a thing. But I think if we can get 10 million people to give $10, $1,000, you know, that may be a starting point. So I would recommend that our speakers tonight can start from there. And the second question that I had in the chat was, this is for the special guests in the teams. We heard we had the oncologist team and various help teams. What part did the spiritual side play in your recovery? Because cancer is an anxiety-ridden disease, and we need that spiritual part to alleviate some of our fears sometimes.
In my case, being an Episcopalian or Anglican, I am a member of the Cursillo community in the Episcopal Church here, and they were extremely prayerful, and they surround me with that prayer support and clergy team. I have a spiritual advisor, and when I am, having my low moments, because I do get those, I can call him up and speak to him. But the Curcio community in the Episcopal Church has been very helpful in that form. Like, just before, every time I had a procedure to go through, if there are not 6 or 7 members of the Curcio in our district, in the Brooklyn area or in the Long Island, they would come to the home and have a prayer session with me the night before. And that was, to me, it was very, very extremely helpful. It calmed my nerves. It was like the night before my double mastectomy, there was a prayer session. My sister-in-law cooked soup, and then the prayer session went on, and it really calmed me, because I was joking as they were taking me into the operating room to remove my girls. So that took a burden off. It helped a whole lot. So I would advise anyone going through, prayer is a powerful thing, and we need the prayers going up for each and every one of us as we go through this difficult journey.
There is a whole body of research going back many years now that shows that people with a strong faith system and support, they do better in managing cancer and survival and other diseases. So I think that, thank you for sharing that with us. There's another question in the chat, and the question is, will one of the doctors be discussing neuropathy? I have chemo-induced neuropathy in my hands and feet. It has been 2 years since chemo, and I'm still trying to recover. Dr. Harvey, maybe.
Let me take that one. Yes, I mentioned it in the list of I put up, but because of time, I didn't spend a whole lot of time on it. It is a problem. There are some drugs that we know will very often cause neuropathy. Some of the taxanes and some of the platinum compounds. There's a very interesting study ongoing. It raises the question that this might indeed be more of a problem among African-American women, or men for that matter, than Caucasians. And there's an active study trying to work this out. It looks as though there may be a genetic reason that we haven't fully uncovered. And this study is a small study, but I think in the next year or two, we will have specific results. If it is true that neuropathy is more common in African Americans, for example, what that might mean is alternative drugs or alternative dosing of the drugs. You're right, it is a bad problem, a bad thing to have to go through, and there's not really particularly good therapy for it. We treat diabetics reasonably well for neuropathy, but the chemotherapy-induced neuropathy is pretty resistant to such therapy. And I hope that we'll find a way of decreasing the risk by simple things like, for example, dose changes.
Thank you, Dr. Harvey. And again, as you said earlier, I think we're only really now beginning to focus on the differences, the genetic differences between African Americans and Caucasians. And so when it comes to the biology of the cancer, as well as the response to treatments, as well as other psychosocial needs. So that is
exactly so. Yes.
There is another comment/question in the chat from Ms. Sobers. It says, a question of sexual activity after breast and uterine surgery and the hormone concerns. Apparently a doctor told a patient to hold off quotes on that activity after surgery. I don't know, Dr. Mays, Dr. Mays, would you like to tackle that for us?
Sure, absolutely. No, it is part of wellness. It's important to maintain that intimacy with your significant other. So there is no medical contraindication to sexual activity after surgery with respect to breast cancer management. I don't believe so either with hysterectomies, but I don't perform those routinely, but certainly not. With the hormonal therapy, certainly there is a concern and issue with vaginal dryness, which can make intercourse not, it would make it difficult, but there are ways in which we can mitigate that, such as lubricants and other ways in which we can make sure that patients can still maintain that activity if they desire to. And we also encourage it because oftentimes what happens, particularly if a woman has a mastectomy, really becoming more comfortable with their new normal, oftentimes they tend to retreat and not want to engage in that intimacy with their partners. So I encourage it from day one, and also get the husband involved, or whoever the significant other is, I should say.
Again, I strongly agree with that, Dr. Mays. I did have this in my list, but couldn't get to everything. One of the things that we're doing is getting the obstetricians involved and have them help us manage these patients. They're bad problems. There's loss of libido, there's pain, there's bleeding, there's quality of life goes downhill very quickly. And there's no reason for women to suffer in this way. And I think this would be something that we should put more emphasis on and more collaboration with the obstetricians. And there are some therapies, some medications that are being looked at when a woman, for example, has a hormone positive breast cancer. We shy away from offering topical estrogens because we think that will be bad for the cancer. In fact, there are ways of using very small doses of local estrogen that can significantly improve a woman's health and overall quality of life. And I encourage my colleagues to look into these when we see such women. It's a very troubling situation.
Yeah, thank you both. I think it's so important for us to as you said, Dr. Mays, people to get accustomed to the new normal. I think maybe some of this is a hangover from the bad old days where cancer was, you got cancer because you did something wrong. All of the very negative and blaming behaviors and so on that went along with the diagnosis of cancer. And instead of looking at it as another chronic disease that you need to learn how to live with, and there are ways to help the patient through it. So we still have a lot of work to do, both from the medical as well as the patient perspective. Ms. Wilkinson, I see your hand is up.
Okay, my question is for Ms. Sobers. You mentioned that patients come to you after the doctors inform them that there's nothing else they can do for them. I would like to know, is this because the diagnosis was done late in the process, or is it because of financial reasons?
No, once they have done all the treatments within the hospital, or they've had the chemo or the radiation, it's beyond stage 4. The liver has become affected, maybe the brain, certain organs within the body has now metastasized, and then they say, well, makes no sense. Futile treatment does not make sense of increasing chemo or radiation, and go home and enjoy your family.
Okay, so my
go ahead, sorry, go ahead.
So are they listening to you that they should not tell the patients, there's nothing else we can do? Because we all know statistically that patients with cancer, they survive well because of their attitude and their family support. So doctor can say one thing, but if you have that support and you have that will to live, you can live. So are the doctors cooperating with you?
Yes, as a matter of fact, we've been doing lots of education, and one of the key things is that we have asked that we come in with when you're going to discharge the patient, allow palliative to come in and have a chat with the person and their families. The key to this is that in terms of having a conversation, communication is very important with the patient and their families. And in terms of, I always ask them, what do you want to do the rest of your life? I could ask everybody here now on the platform because we don't know what will happen to us. So what do you want to do? What's the rest of your life? One lady said to me, I just want to live to see the Christmas lights. I want to see the Christmas lights. So they have goals in view. I want to see my children. I want to have, go to the wedding of my daughter. So I said, let's do it. We have had patients that have been sent home with nothing more, with nothing else they could do and live for 2 years. We gave them palliative care for 2 years and they were happy with that. So yes, we have been chatting with the physicians and the families involved.
I'd like to defend the physicians a little bit, although I agree with a lot of what the two last speakers have said. The one thing we cannot do is lie to patients. We have to deliver the truth as best we can.
Okay.
But in my experience, it's not often what you say. It is more often how you say. And there are ways of, I think, a good, competent physician, surgeon, or oncologist, or what have you, deliver the message with empathy, even though you are speaking the truth. And I think we have to do both.
Right.
I think, Dr. Harvey, and maybe we're saying the same thing, because the reason I mentioned your exceptional patient satisfaction award is because this is really the level of care we need as oncologists. I think what Ms. Sobers is saying is that even if you choose to say there's nothing I can do medically, or I have no more, radiation or that type of option, there's always more we can do. It could be as simple as holding their hand and spending a few moments with them. But I think, again, what Ms. Sober says about allowing them to set goals and what they want, and sometimes not allowing their family to put goals on them, but to really
So beautifully said.
patient wants. I think that's really key.
Can I just chime in for just a moment?
Yes, please.
One of the things that I really have found, particularly with palliative care, is that as a society, we have created a stigma as to there's nothing else to be done. We're sending you here to die. And palliative care should be involved as soon as the cancer diagnosis is given, regardless of what the potential outcome is going to be. Because I think if we move away from the you're going somewhere to die to the how can we help maintain the quality of life for however long that's going to be, none of us know. As clinicians, we can only give you the information based on our experience and the data, but no one knows what that time is. So palliative care should be a partner with surgeons and oncologists in maintaining the quality of life. And if that is the objective, I think a lot of the stigma that's placed on palliative care would be removed.
I heartily agree. However, there are times, there's palliative care and there's hospice care. One can lead to the other, but they're not the same thing. And so when we talk about palliative care, I absolutely agree with Dr. Mays. That starts at the time of diagnosis, and initial treatment. And that's what palliative care is. It is not necessarily the end of life care. It may merge into that, but palliative care is highly important and should be distinguished from hospice care, which we need at the right time.
Thank you. We only have a couple of minutes left. Dr. Paris, I saw you had your hand up briefly a little earlier. Is there a comment or something you would like to add?
Okay, my view of palliative care is it's not limited to cancer, but it can be any disease basically. And as was said, of course, we think of it in the cancer sense, but really it applies to any disease. And one of the things that they've done or tried to do is to introduce palliative care training or experience into the curriculum at the UWI hospital in Barbados, so that now the house staff get to spend time doing palliative care, and which is very critical. There's a dearth of this experience throughout the world, but it's becoming more common now for that to happen. I wanted to talk, we talked about chemotherapy, etc., but I want to ask a quick question about robotic surgery. Has that played, that's been an advance, I presume, in certain diseases? I wonder if you guys can comment on that. Also, another advance that I was thinking of is transparency. In the past, people weren't really told much about, you have cancer, period, especially at home. And that was it. Now you can actually see your medical records by signing up for the patient portal, and you see everything there. So that's an advance, in my opinion, in terms of transparency. And in terms of Ellen Larry's comment, we have discussed this in the past in the MBA and the advocacy group in Barbados. And the conclusion that we had is that it has to come from at a governmental level. Maybe the CARICOM leadership has to get together and say, and go to PAHO and say, look, establish a regional facility that can do all this specialized testing. And with that, they can probably get it done. But an individual organization like ORS, BACA, or the FPC will never get the resources, I don't think, to fund such an entity. So those are my quickies.
Thank you all very much.
Question or one quick question?
54, I think I will, sorry, Dr. Harvey, one more last comment.
Yes, and it refers to something you said earlier, thinking about a regional center for cancer. And, it'll take a while, but I think it's doable. And I'm wondering, as a region, what our colleges and universities and practices in medicine are doing. We can combine and have these folk work together and with us up here in the States, and make a real effort on cancer care in underserved locales and in underserved people. And I think that's something we could put together quite quickly, and hopefully improve the outlook of our patients in the islands.
Thank you, Dr. Harvey. On that note, I'll pass it over to Dr. Ali for a few closing remarks. Thank you all so much.
Working. I started by saying, how many ways can I thank you? And I have two quotations, and they're mine. Knowledge is useless unless it's shared. And the other one is not for ourselves alone, but for the benefit of others. And we've done that this evening. We've done that eloquently. And I don't want to go through name by name, but I will mention Dr. Harvey have compressed 4 hours of a lecture series into half an hour. And I could have listened to him for the rest of the evening because it's enlightening, it's fresh, it's educational, and it gives hope. And I think at some time we'll have to get him back so he can continue this road. Let me give a shout out to Dr. Nichols, although he was not able to make it. And I hope that we are able to send the recording of this session to him so that he can see how we had Barbados in focus. And at some time he can even write a paper expressing to us the shortcomings or the problems that they face in Barbados and how we can help. For Dr. Simone Mays, I thank you, because it was the last moment that we got together and you readily agreed to speak on the issue. And I now know that your name does not have an E in it, it's M-A-Y-S. And that was one of the problems. After I discovered that your emails were bouncing back, I said, well, let me take the E out, and it worked. So I thank you again, and you really have brought some issues to light that you've shared to all the listening audience, to those who have cancer, and for those who unfortunately may be diagnosed with cancer, that there's hope in treatment. There's hope in research. There's hope in the current modality of treatments. If I may add, I was in oncology at Mount Sinai in the 70s, and we thought we had the cutting edge at that time. Some of you may have heard about Dr. Holland, and we used to refer to his book as the Bible. We have moved away from that, far away from that, but the groundwork has been set. And this evening, the groundwork is set, and we'll continue to research and explore beyond horizons that we would never think that we can get there. So we who are practicing, and even those who are retired, need to continue the work. For our two special guests, they're brave. They have gone through the therapies, the treatments, the downs, the ups, and they were still able to come and bring it to us to show that the human side of a treatment is evident, and the caring side is evident. And I have to shout out to the nurses who are not here. Some are not here, but for the nurses all over the world who treat cancer patients, because without that holding hands and sympathy and understanding and empathy and answering the call bell in a few seconds, the recovery may be prolonged. Again, I shout out to the nurses. Ms. Bovell, you are exceptional. Ms. Allen, you are exceptional. And I would certainly like to reach out to you, and when we are forming this coalition, to get you both together and other cancer patients so that we can forge ahead and do things that we have to do, that we must do in order to bring the developed countries up to scratch. We never know when we'll need them. Let me reach out to United Barbados, who allowed us to use their platform for this program, Ian Watson and his team. Because we know that hopefully we would get more than 100 people, and our Zoom platform could not accommodate it. To the technology team, who really, all the hitches that we had went off smoothly. I couldn't do it. I can't even get the thing on mute on time, but so we have to give thanks to all the entire team that put this together. The Barbados Nurses Association, BACA, and CAMSA. A program like this is not easy to put together, as all of you know, but cooperation will get anything done. As we say in Chinese, many hands make light work. And if you put 10 sticks together, it's more difficult to break than if you have one. So that's why we coordinate these efforts. Dr. Callendar, last but not least, you have merged it. You are a painter, an artist, a baker, and since I am a formulator, you're a formulator. You've put all the pieces in one jar and make it whole. I thank you for agreeing to serve as a moderator. You know, some people get scared because they have to listen, they have to observe, they have to be knowledgeable. And you've done all these things. And I know that when we have another forum, whether it's be on oncology, but some part of cancer, that we can call on you and get an enlightened, sensible, smart program. Again, I thank you. If I left anyone out, I said the Barbados Nurses Association, CAMSA, and BACA. And all the listening audience here in earshot and abroad, wherever they're signing from, I hope that you have listened, digest, and will be able to share what you have learned this evening with your family members or those friends who may have cancer, that cancer is not a death sentence. I remember when I was a kid and you hear people in the district there whispering, oh, she got the crab. And not another word is said about it. There was a fear around it. And the fear is no longer there, but we have to continue, we in the healthcare field have to continue to find ways to make it easier for the patients. Because anytime you hear the big C, there's a fear. Even if you have knowledge that you can be treated, there's still that fear. And we want to make it, as Dr. Harvey said, possibly, if not eradicated, a chronic disease, just like high blood pressure or diabetes, that we can get a management style around it. If there's anyone I left out, it's not by
And the Reverend Dr. Laurel Scott.
I will get to her. As I said, I asked what part the spiritual end play in the two special guests' lives, and they echoed it clearly. The reason that we ask a reverend, a minister, or someone of the faith to lead us in prayer when we start these proceedings is because we all believe in faith in some way or another. And we believe that in the medical field, in the caring field, that faith and spirituality is one of the components of getting us better. There are other ways, but we believe. And Dr. Scott, the Reverend Dr. Laurel Scott, I thank you for agreeing at the last minute to lead us in prayer, and your prayer will continue to be echoed throughout the lives of the presenters and the lives of those people who have cancer and being treated from cancer and recovered from cancer. I thank you all, and I wish you well, be safe, and continue the work. And you'll be hearing from me to form that coalition to get all the oncologists and surgeons on cancer together so that we can help those who need our help more. I thank you. I'll turn it over back now to the president of BACA.
Okay, well, thank you, everyone. Thank you for joining us. And I hope you will come back next year and that we will have a very informative presentation for you. So stay tuned, and thank you for supporting BACA and also CAMSA and the nurses. Have a good evening.